Hi, my name's Autumn Avalos, and I am in the AG-ACNP track. I am doing my Grand Rounds presentation, and my Grand Rounds presentation is on CMV Syndrome, an unusual case presentation. So, the objectives of this presentation is to review the case presentation, discuss CMV or cytomegalovirus and CMV syndrome, address complications of CMV infection, discuss manifestations, pertinent diagnostics, differentials, and treatment of CMV. We'll review some relevant articles and evidence-based guidelines, and then go over our conclusions and provide you with an opportunity if you have any questions. So my case presentation was, and full disclosure, this actually, I finished my practicums last semester. So unfortunately, I didn't have every bit of information that I would have hoped to have had for this Grand Rounds presentation, but I kind of piled together what I could find from my XAT, and I'm kind of going to roll with what we do have. And unfortunately, I never ended up finding out what happened. Unfortunately, that sometimes just is how it rolls when you're in ICU, but we're going to work with what we have. So the presentation was initially a 40-year-old male who presented to a rural nonprofit hospital following approximately 2 weeks of progressive weakness. So that was his chief complaint, was just feeling weak, malaise. He endorsed having what seemed like a viral illness approximately about a week prior to the onset of weakness. And his weakness began with bilateral lower extremity weakness and was progressive. His history included hypertension, and then prior alcohol use, and as well as prior illicit drug use. So initially, he was admitted to med-surg. He went up to the floor, and hospitalist admitted the patient. They consulted neurology, just kind of given the history of present illness. There was concerns that the patient was presenting with Guillain-Barré. So neurology was consulted, and they had low threshold to start the patient on IVIG. So initial workup. His initial workup, diagnostics and plan. So he had a CMP, CBC, lactic acid, blood cultures that were drawn, UA with reflex culture. He did have a respiratory panel that was negative, and a head CT, which was negative. He was admitted to the floor, neurology was consulted. He didn't have bulbar weakness, so there was less suspicion for myasthenia gravis. And he didn't have any complaint of headache, nuchal rigidity, or photophobia. So there was less concern for possible meningitis. The patient was initiated on IVIG, and they did go ahead and they did a LP. So the results, his CBC, he had a white count of 16, hemoglobin of 10.2, hematocrit 24, platelets 143,000. Magnesium was 2 on his CMP, sodium 137, potassium 4.2, chloride 108, CO2 is 17, BUN 40, creatinine 2.3, AST 252, ALT 114, alk phos 108. Lactic acid was 2.1, Blood cultures were pending. His UA was reassuring against any underlying UTI, and UTOX was negative. As I said prior, respiratory panel was negative, head CT was also negative. So the progression of illness, initially, as I stated, the patient was admitted to just the general medical surgical floor. He was weak, but his vitals were stable. On hospital day 1, he received his first dose of IVIG. And then following this was around like night shift, had just kind of come on. And following IVIG administration, the patient became tachycardic, hypertensive, agitated, more confused, short of breath, and then had progressive increase in oxygen demands. So they ended up calling a rapid response. The patient was quickly placed on 15 liters on non-rebreather. The patient was then placed on BiPAP and transferred to the ICU. Chest x-ray was obtained, which revealed diffuse bilateral pulmonary congestion. He had bilateral opacities noted. And once the patient arrived to the unit, there were concerns that he was unfortunately failing BiPAP. So the hospitalist, the nocturnist at that point, decided to proceed with intubation. Preload and afterload reduction probably would have been helpful, but they just kind of erred on the side of caution and just proceeded with intubation. So what now? So my first question coming on, because my practicum at this point was in ICU, and I was working with our intensivist. Both units were pretty full. We were covering both units, and so the intensivist says to me, like, hey, do you want to go see this patient? He's new. I haven't seen him. I haven't reviewed anything. All I know is he was intubated for respiratory failure. So I start looking into this patient, and I'm like, what was the cause for him to get intubated? What caused this? So after kind of hearing the report from the bedside nurse, it sounded like the cause was not necessarily a respiratory failure due to like a progressive ascending paralysis that would be consistent with Guillain-Barré, but rather it was like flash pulmonary edema, right? Because the patient they were tachycardic, they were hypertensive, chest x-ray had, revealed diffuse bilateral pulmonary congestion. So following intubation, though, when I arrive into the room and start assessing the patient, I notice that the patient is now profoundly hypotensive, and he's up to 20 mics per minute of norepinephrine, Levophed, and vasopressin is at 0.04 units per minute. The bedside RN at this point also informs me that there's been some EKG changes, that nocturnist did order a troponin, which eventually came back critical. EKG revealed diffuse ST elevations throughout all leads, which at this point was kind of concerning for pericarditis. At this point in time, I ended up doing a point of care ultrasound, which showed global profound hypokinesis noted, ordered a formal echocardiogram. The results of that revealed and this patient had no history of heart failure. At this point in time, the LVEF was 20%. So as I'm getting this information, my attending's in a procedure, and I kind of poke my head in at him, and I go, "Hey, I think we need to consult cardiology." And he goes, "Yeah, go for it." I tell him why. He says, "Go for it." So I call cardiology, consult them, and they go, "Oh, as soon as I read this echo, I knew you were going to consult me." And at this point in time, based on the findings, we initiated the patient on dobutamine, which significantly helped. The patient did have a line, they had an IJ, and we ended up doing a SCVO2, so we got a VBG off of that, and then we also followed lactic acid. Following intubation, the lactic acid did go up. After initiating the patient on dobutamine, this trended down nicely, and the patient's pressor requirements came down as well. The patient was also noted to be febrile. He was 38.5 was his Tmax. And then the LP neurology was looking at it. They're like, maybe it's a viral meningitis. He didn't have nuchal rigidity, but just to err on the side of caution, they did start the patient on acyclovir. And then we started the patient on ceftriaxone, given the new fevers. And uncertainty if the patient did aspirate at any point in time. So I'm going to kind of segue now into what is CMV. At this point in time, as I'm sure you can preclude, we ended up finding out the patient had a new infection of CMV. But prior to finding out, I'm going to kind of discuss this because this wasn't really on my radar. My first question was, why does this patient have this new heart failure? He's not drinking anymore. He's not using illicit drugs. Ethanol level and UTOX were all negative. He's young. He's intubated. I can't ask about family history. There's no family around. I don't know if he has a very strong cardiac history. So at this point, my attending and I are like, okay, well, we have to consult cardiology because he needs an ischemic workup. And then following this, neurology the prior day had actually sent a CMV, IgM, and IgG, which then ended up coming back. The IgM came back profoundly positive. So what is CMV? A double-stranded DNA virus in the herpes viridae family that can cause either disseminated or local and organ disease in individuals who are immunocompromised, such as those who have HIV. That's kind of like the most common thought when they're immunosuppressed is, oh, do they have HIV? We're going to kind of go over that a little further. So now, before going into CMV syndrome, I want to discuss some other complications of CMV. So some of the complications that you can have with active infection include retinitis, myocarditis, pneumonitis, pancreatitis, hepatitis, encephalitis, colitis, esophagitis, nephritis, Guillain-Barré, myelitis, and polyradiculopathy. To formally diagnose these conditions, on the left, you have to have viral isolation from the respective organs. So if you're concerned about encephalitis or ventriculitis, you have to have a viral PCR following an LP without it being like a bloody tap. Or for retinitis, you need to have a PCR of vitreous fluid. If you're concerned about myocarditis, you need to have tissue histopathology, so a biopsy to confirm. Now, CMV syndrome, on the other hand, it's a disorder in which there is proven active CMV infection and disseminated disease, or multiple target organs affected. So you have to have 2 or more of the following in addition to evidence of active infection. And how you prove that there's active infection is with either viral isolation, rapid culture, antigenemia, or nucleic acid testing with at least 2 of the criteria listed. So 2 of the criteria listed include, or the criteria listed would be fever of greater than or equal to 38 degrees Celsius for 2 or more days, new or increased malaise, fatigue, leukopenia, or neutropenia at least 24 hours apart, greater than or equal to 5% atypical lymphocytes, thrombocytopenia, or a drop in platelets of at least 20%, and elevated LFTs. With CMV syndrome, you don't necessarily need histopathology because there's multiple organs that are affected. Because of this, the diagnostic criteria are laid out clearly. It's impossible to prove that each affected organ is the result of CMV infection. Therefore, it's considered that it's like not a proven diagnosis, if that makes sense. And then you also have a mononucleosis-like syndrome, where there can be lymphadenopathy, rash, fever, malaise, and atypical lymphocytes. CMV can cause this syndrome just like Epstein-Barr virus. They're actually very similar in how they infect individuals and the fact that they become latent and can reactivate later on. Now, what is the pathophysiology of CMV? So let's look at immunocompetent versus immunocompromised individuals. So in immunocompetent individuals, CMV is maintained in a state of balance when it's in the latent phase. In immunocompromised individuals, CMV begins to replicate, and cytotoxic CD8 T cells control CMV reactivation. However, when you're immunocompromised, this replication leads to reactivation. There is a seroprevalence between 24 to 100%, and this increases with age. So odds are you've been infected. It's transmitted via bodily fluids like saliva, fomites, transfusion of blood products, sexual contact, solid organ transplant, or hematopoietic stem cell transplant. And like with other herpes viruses, it has transcriptional silencing, which allow it to remain dormant within monocytes, and then it can reactivate later. And then I think an important thing to note too is that in majority of individuals who are immunocompetent, you're going to be asymptomatic. So we often, this isn't the first thing we're thinking of in healthy individuals. Okay, so now let's move on to diagnostics, treatments, and differentials. So workup for CMV, if it's in your differential, you're thinking about it, you've probably already done most of the basic things. So CBC, CMP, you might not have checked for atypical lymphocytes quite yet, or done a smear, but respiratory panel, cultures, maybe blood cultures, you know, if they have a productive cough, sputum cultures, if you were concerned about, you know, UTI, urine cultures. And then really, there are different ways to assess for active CMV infections, but probably the easiest and the fastest turnaround is going to be depending on where you're at, what kind of institution you're at, is going to be the CMV, IgG, and IgM. And these are going to tell you 2 different things. Obviously, IgG, if you've had a past infection, and IgM is if you have a new active infection. And then you really need to do a workup for whatever organ system is affected. So depending, like say you're concerned that maybe it's a pneumonitis and they're intubated, maybe probably going down the road of if it's bad enough and they're already intubated, doing a bronchoscopy so you can have a BAL, that kind of thing. So if workup is positive for CMV infection with either disseminated or isolated end organ disease, then you have to work up the patient for an immunodeficiency. So is this a primary or secondary immunodeficiency? And we're really kind of looking at, is this a secondary? Like, do they have HIV? EBV, infectious mononucleosis, viral hepatitis, autoimmune hepatitis, and then also, do they have cancer? Have they been on chemo? Did they receive a solid organ transplant or a hematopoietic stem cell transplant? Those of note, those individuals in particular, they typically prior to transplant, they undergo testing for CMV, and they usually, from what I've read, I don't have firsthand experience with this, but from what I've read, they typically will take antivirals for prophylaxis. And then, what am I missing? Oh, if they do end up, this is like a new diagnosis of HIV, or even if it's not, it's probably helpful to get a CD4 count. And then differentials would include sepsis, UTI, Guillain-Barré from other viral illnesses, which you probably already ruled out with like a respiratory panel, or maybe it was a while ago and so they're not popping positive anymore. Sometimes it's hard to tell. The differentials are wide, and the diagnosis and treatment often require multiple specialists. You're looking at, whatever organ's involved, having that specialist on board in addition to probably infectious disease. And then treatment. So you have ganciclovir, valganciclovir, and those are your first-line agents. And then you have cidofovir, foscarnet, which those are your second line. And then there's also maribavir and letermovir. So ganciclovir is typically the treatment of choice, especially in severe cases of infection. And it inhibits viral DNA synthesis, but it is hematologically toxic. And there is antiviral resistance, so it's not always effective. Valganciclovir, it is an oral prodrug of ganciclovir. It can be given in less severe CMV infections. It also has hematologic toxicity and antiviral resistance. Cidofovir it inhibits viral DNA polymerase independent of viral activation. It's a second line, but it's considered nephrotoxic. And then foscarnet it directly inhibits the viral UL54 DNA polymerase. It's another second line agent, but it's also considered nephrotoxic. There's also some newer agents like maribavir. It has a different binding site. So it's a selective inhibitor of the viral UL94 kinase. So it has a different resistance profile from ganciclovir. Letermovir It's actually the newest antiviral, and it was approved in 2017 for prevention and treatment, and it works by targeting viral terminase complex, which inhibits CMV DNA cleavage and packing. It's relatively safe, and with minimal side effects. There's also, of note, oral and IV formulations. And I didn't put it here because treatment length, it's going to really vary person by person, everything I could find. So it's going to be prolonged until there's some immune recovery. Typically, ideally, you'll follow up in 2 weeks with CMV PCR until it's undetectable, or if this is a new diagnosis of HIV, or AIDS, you're gonna end up with following treatment until CD4 count is greater than 100 for 6 months in those with HIV. If this is a new diagnosis of HIV, you'll also have to start them on antiretroviral therapy as well. And then for this particular patient, since his complaint was weakness, but he obviously had multiple organ involvement, his biggest non-pharmacologic intervention that we could provide him was PT-OT to assist with that weakness. And in the end, he actually had, following intubation, and, it was hard to tell. He already had some mildly elevated LFTs, but then following, they kind of skyrocketed, and it was hard to tell, was this because of shock liver? But overall, his clinical picture still fit CMV syndrome. He had multiple organs that were affected by his illness. And unfortunately, I didn't hear what the follow-up was, but of note, we did end up starting him on, ganciclovir. Infectious disease was consulted, and we ended up extubating him the following day, and cardiology was following. But this was a big life change for this patient, because he didn't have a history of heart failure. He had been sober for a while, and now he's starting a lot of drugs, because you have all the drugs that needed to be initiated for this new diagnosis of heart failure once he was clinically stable enough to start those, as well as if it was a new diagnosis of HIV, initiating him on antiretroviral therapy, and then the ganciclovir. So you're looking at starting a lot of medications with this. So guidelines and relevant articles. This CMV, it requires consultation with specialty of whatever organ is affected. Infectious disease is typically consulted as well. There are numerous articles regarding CMV and disseminated disease. The NIH has standards of care that are listed, and so I have a link to that below. And it actually has some pretty great, they point out, really this needs to be tailored to the individual and their immune competency, their immune response. But they kind of provide some basic guidelines to kind of start and when to reassess, which usually is around 2-3 weeks. And then kind of repeating labs, seeing how they're doing, and going from there. But they expect that it's going to be a prolonged course. sometimes even 3 to 6 months of being on this. So what now? So for this particular patient, following this, we ended up consulting infectious disease, cardiology, neurology, intensivists, and then once the patient moved out of the ICU, handed over to hospitalist. So my suspicion, and this was infectious disease suspicion as well, is that this was going to be a new diagnosis of HIV. After finding out that the patient was positive for CMV, there was less concern for like an ischemic cardiomyopathy. His EKG, was kind of global. There was no concerns for any particular coronary involvement. But ultimately, I don't know what cardiology ended up doing, because ultimately that's, their call. The patient, he lived at home with his roommate, obviously former alcohol and illicit drug use. He did have like a lower socioeconomic status. There were some concerns with affording necessary medications. He did have some family that would come to visit, and they had a strained dynamic. There was willingness to participate in plan of care and understand, and he seemed like he understood his illness, but I think it was a lot of information thrown at once, and he was still pretty ill. He was critically ill. So he definitely, that was, I think, part of the handoff, was he's going to need a lot of education following ICU discharge. And then follow-up and evaluation is ongoing for this patient. He definitely, we had case management, social work involved to kind of assist, because I don't think he wasn't set up with like Medi-Cal. So there were definitely, he had some other needs to help support him through this time, and to get him established with the care that he needed when he is discharged, or was. So ultimately, the conclusion of this is, don't forget the differentials. Although I don't know what happened to him, sometimes the less suspected diagnosis is the correct diagnosis. This was a great reminder not to get tunnel vision on the most probable diagnosis, and to always remember other possibilities in the workup. Here where I live, we actually, unfortunately, we see quite a bit of Guillain-Barré, and I think even that is like an unusual diagnosis, but I think, the history of present illness kind of pointed to that. And he never, like, once we extubated, prior to extubating him, we did a NIF, or NIP, negative inspiratory force, and it was adequate to feel like we could successfully extubate the patient. And so he ended up doing well, and he never had to be reintubated or trached, nothing like that. So it seemed like this was less of like a Guillain-Barré, and maybe there was some encephalitis, definitely a little bit of like a myopathy from this infection. And then he definitely had like myocarditis, although we couldn't formally prove that without a biopsy. So, but it was a great reminder to always remember other possibilities while you're working up patients. And if you have any questions, feel free to message me or leave a comment, and I will get back to you as soon as possible. Thank you. And then last, here are my references. These all had really great data. There's a lot of published work on CMV in following organ transplantation, and so some of the information gathered was from those articles, as well as like HIV.org, the Royal Australian College of General Practitioners, and then clinical infectious diseases, gastroenterology research and practice. Yeah, so there was some good data out there. Some of it was more focused on, like GI involvement, whereas others like HIV.org and as well as the Stat Pearls Publishing kind of looked at everything and all possible organs of involvement and what that might look like, and then possible treatment options. So if you have more interest, those are available to you. And thank you for your time. If you have any questions, feel free to let me know. Leave me a message or a comment, and I'll get back to you as soon as I can. Thank you.